Hello everybody, this is me, Dr. Sergio Rovinski from Shoulder Planet, here from São Paulo, Brazil. I am very honored to be participating here from Wiroc, this lovely meeting organized by BOSS, Bombay Orthopedic Society, and I invite you to see all of the videos that I have sent to this wonderful meeting and to learn the most you can with them. And if you have any doubt, don't hesitate in sending me an email. My email is sergio@shoulderplanet.com.br. I thank all of the organization of this lovely meeting, and I hope you have fun seeing all my videos, and Dhanyavad. Slap lesions are quite uncommon lesions, and nowadays we know that they are much less common than what was initially proposed about 10 or maybe 12 years ago. Slap lesions can occur in the shoulder in two different populations. So the first group is the one composed by young patients, generally male, usually before 40 years old, when these patients have a very well-defined trauma event onto his shoulder. So this slap is caused by a fall onto an outstretched arm during sports activity, just like the fall that we are seeing here in this photo. Obviously, a fall like this can happen in any sports activity, and still, even a fall like this can happen accidentally. But generally, the fall is related to some kind of sports participation. Also, in the second population, we have the overhead athletes, and they develop this slap due to the repetitive so-called peel-back mechanism in sports activities, in sports modalities like baseball, volleyball, handball, basketball, and even others. So in this present case, I'm showing a case about a 23-year-old male who is a professional soccer player in Brazil. He had a fall in January 2013 during a professional soccer match onto his outstretched left arm. He felt intense pain in his left shoulder just after the trauma, and he had to immediately leave that soccer match in which he was playing. He was so taken to emergency room, and some x-rays were taken, revealing absolutely no abnormalities. He was told so by the doctor who saw him that he had a simple shoulder contusion, and he was given nothing but ice, rest, and some painkillers. But since then, he started to feel pain in his left shoulder during his soccer games, and he insistently complained that he felt that his shoulder was quite loose when he was playing soccer. In spite of not having any shoulder dislocation in his medical history, he had a vague sensation that he could dislocate his shoulder. So after 5 months of complaints, 5 months after the trauma, he came to my office. This patient was sent to me, and he had absolutely no signs or not even symptoms of rotator cuff pathology. On physical exam, he had pain and some slight apprehension, especially in Job's relocation test. We asked for an MRI, and the exam revealed a very large slap tear. And the slap tear, as we have seen here, had a continuity with a large Bankart tear also. Anyway, it's very important to say that usually in slap cases, the MRI images are not so clear as it was in this present case. Anyway, an arthroscopy was indicated, and so this is his arthroscopy. So here we are, this is the left shoulder. Here we are seeing the labrum and a very important tear in the root of the biceps, a very important tear indeed. And here we are seeing a large Bankart tear also. So as usual, we started to establish the anterior portal with a spinal needle, and then we opened the capsule with a mosquito to enter with the anterior cannula. So now the cannula is inside the joint, and once we would have to perform a biceps tenotomy and a biceps tenodesis, we passed a whip stitch with a spinal needle with a number 2 proline suture through the biceps, and we retrieved that out of the anterior cannula, and then we started to perform the biceps tenotomy, that is supposed to be a very fast and simple procedure. So now the tenotomy is finished, and here we can see a very large Bankart and slap lesion again, and the labrum was literally falling into the glenohumeral joint in this case. So again, with a spinal needle, we established a good position for anterosupralateral portal, and then we very delicately, very softly entered with 11 blade, and we opened the capsule to enter with the second cannula. We enter it then with a mosquito to open the capsule, and then we use a Wissinger device to enter with the second cannula. So then, with the second cannula in place, we started to debride and to create a bony bed in the very anterior part of the glenoid, just to fix the labrum and the Bankart with the slap lesion, and this is exactly what we are used to do in standard Bankart repairs. But in this case, the difference is that we would have to go a little bit upper. So now we are in something about 1 o'clock, and now we are in the upper part of the glenoid, just creating a bony bed in which the labrum would be reattached. So here we can see again the labrum falling into the glenohumeral joint, and the difficulty that we had to see the Bankart itself. So with a simple basket, we removed something about 2 or 3 millimeters of the articular cartilage to put the first anchor as inferior as we could. This is something about the 5 o'clock position, and here we are introducing a 3.0 monoloaded bioabsorbable anchor. This is an anchor from Lymphatech. And then at this moment we inverted the camera because we wanted to look as low as we could, and through the anterior cannula we entered with a bird beak to pick up as much labrum as we could and as inferior as we could. And here we are something about the 6 o'clock position. So for the anterosupralateral portal, we used a suture manipulator to bring the sutures to that very inferior bird beak. And in a retrograde fashion, we passed the first suture through the very inferior part of the tear. Now we are tying the first knot, putting on a lot of compression in order for the labrum to heal in the bony bed that we had just created. Then the knot was cut, and then we would have to put a second anchor. Here we have something about 3 or 2 o'clock position, when we are putting again a 3.0 mono-loaded bioabsorbable anchor. And once the anchor was in place through the anterior portal, the anterior cannula, we enter with a bird beak as inferior as we could, and in a retrograde fashion again we passed the second suture through the labrum, and here we are tying for the anterior cannula the second knot. So here the knot is finished, and at that moment we would have to put a third anchor in the very upper part of the glenoid to fix the slap itself. So now we are putting the anchor. This is a third anchor, and again bioabsorbable 3.0 mono-loaded one, and in the same fashion we enter it with a bird beak, and in a retrograde fashion we passed that suture out of the anterosuperior cannula, and here we are tying the third suture from the third anchor. Here we can see that the knot was cut, and at that moment we analyzed the construction, and we decided to put a fourth anchor in something about 3 or 2 o'clock position to give a better fixation, because this patient is very strong and is a professional athlete. And here we are putting the fourth anchor in something about 2 o'clock position. We again entered through the anterior portal with a bird beak, and in a retrograde fashion again we pass it and fix it and tie the fourth suture. So this is the construct of the labrum: a bumper sticker fixing the slab and the Bankart tear. At that moment we removed the camera from the posterior portal, and we entered with the camera for the anterior cannula just to check that the posterior labrum was okay, and it was. The patient had no signs in physical exam of a posterior tear, nor in the MRI, and in fact the posterior labrum was okay. So we came back to the posterior camera. So here we entering again for the posterior portal, and now we see the biceps with the tenotomy and the whip stitch. So at that moment we entered with the burr to create a bony bed in the lesser tuberosity, just up to do the subscapularis insertion, in which we would tenodesis the biceps with an intra-articular tenodesis. So now we are just creating the bony bed, and once the bony bed was created, we entered through the anterior portal with a 5.0 titanium anchor, a double-loaded one. Once we found a good position, we started to insert it in the humeral head in lesser tuberosity, and obviously it must be very well inserted to avoid all the problems that we do know. So now we are checking that the anchor is being well inserted. And once the anchor was in a good place and well inserted for the anterior superlateral cannula, we entered with a suture manipulator to isolate the blue suture, the two legs of the blue suture in the anterior superlateral portal. Then, still for the anterior superlateral portal, we entered with a grasper, and for the anterior portal we entered with a simple bird beak, and very gently, very softly, we passed the bird beak through the long head of the biceps, and in a retrograde fashion again we passed one leg of the blue sutures through the long head of the biceps and out of the anterior cannula. And for the anterior superlateral cannula, we entered with a suture manipulator, and we removed that leg that was passing through the biceps out of the anterior cannula and through the anterior superlateral cannula, and this is exactly what we are doing now. And here we can see that both legs of the blue suture were passing through the anterior superlateral cannula. And then we repeated the procedure. So through the anterior superlateral cannula, we isolated one of the legs of the white suture, and again we grasped the tendon, the long head of the biceps, through the anterior superlateral cannula with a grasper, and we passed a spectrum device with a Prolin suture through the long head of the biceps through the anterior portal, and we isolated that Prolin in the anterior superlateral cannula, and in a retrograde fashion we passed one leg of the white suture through the long head of the biceps. So at that moment we started to tie the knots. First the blue one through the anterior superlateral cannula, and here we can see that we were putting a lot of compression, and then the second one through the anterior cannula. So now we are tying the second suture, the white one, through the anterior cannula, and here we can see that we were really putting a lot of compression in order for the tendon to heal, and then we cut it. So here we see the final construct, and here we can see, as we internally and externally rotate the shoulder, how stable was the biceps with the intra-articular tenodesis in the lesser tuberosity. And here we can see again the final construct of the labrum repair with the Bankart and this slap lesion very well fixed. And so at that moment the surgery was then finished. Thank you.